What's up, YouTube / my students? We're going to go over really the intro to OMM via landmarks, via motion, anatomy, because this is going to be the foundation of really all your OMM learning here. So it's super important to get down right now. Identifying anatomical locations of all these landmarks, as well as going through specific motions and directionality in terms of what you're saying so that we can all be on the same page. We have the center line of the body here. If things are medial, they're going more towards the midline, right? So the sternum is medial to the shoulder, okay? If we're going lateral, it's the opposite. Shoulder's lateral to the sternum. And you can do that even for the forearm, right? The ulna is medial to the radius, okay? Based on anatomic positioning. Now for proximal distal, right? Proximal stuff closer to the center of the body, distal is further away. So fingers are distal to the elbow, elbows distal to shoulder, etc. Elbow is proximal to the wrist. So just basic terminology here. You have anterior surface of the body, posterior surface of the body, kind of similar to dorsal and ventral, right? So ventral is going to be like the front, dorsal is the back, right? Like a dorsal fin, like if you're a shark or a dolphin, etc. Superior or cephalad, so it's when something is like closer to the head is cephalad, something more superior versus inferior, that's higher or below, but that's more going towards the core of the body. So deep is in like the cavity or a chest cavity. Going towards the feet is caudad, cephalad, caudad. Ipsilateral and contralateral, so that's talking on the same side versus the opposite side. So your left shoulder is contralateral to your right hip. Your left shoulder is ipsilateral to your left hip, okay? So I believe those are all the basic terms. So let's go to motion terminology. So flexion, right? Can you show us some flexion? So if you want to stand up and just bend forward. He's flexing, right? He's flexing his neck. He's flexing his hips. Try to touch your toes. Flexing at the hip. Now can you extend? So lean backwards, that's extension globally. We're not getting into specifics, but that's what that is. So try and like go to your side bend right, side bend left. Try to rotate left, rotate right, okay? So that's rotation. Now with abduction, adduction, try to just do that with your leg. He's abducting his leg, and then bring them together. He's adducting his legs here, okay? We did rotation. So supination and pronation. Do you know what supination is yet? Supination?
Laying on your back.
Good guess, actually. So laying supine, right? That's laying on your back. Laying prone is on your front. So pretend you're holding a bowl of soup. That is supination. Pretending you're holding a bowl of soup with your foot. That's supination of the foot, okay? Pronation is the opposite. So like you're playing basketball or whatever, dribbling, that's pronation. Pronation of the foot is bringing it out like that. So try that. Other way, like kind of out, yeah. So it's eversion, all right? A little bit of dorsiflexion of the foot. Okay, so that's pronation of the foot. Inversion and eversion are involved with those motions. So let's say we're supinating the foot. That's also part of that is inversion of the foot. If you pronate the foot, eversion is part of that. Okay, so pronation, supination are umbrella terms. Inversion, eversion are part of those things. Along with, right, this is more some external rotation as part of that. Supination also has internal rotation, right? Now plantar and dorsiflexion, right? So push on the gas. That's plantar flexion. You also get motion of the talus that goes forward, and we're getting a little deeper into biomechanics, so don't worry, this is just extra. Now try to bring your toes up and back. That is dorsiflexion of the foot and ankle, okay? All right, so that's it for some motion terms. Now we get into planes of motion. So we have our transverse plane. It's literally like chopping you in half. Like think of a magician who just like cut his assistant in half. She's like wiggling her toes, like, yeah, this is so fun, I'm getting paid. Now, you also have your axis of motion is the vertical axis. So, you know, this guy is suspended on a vertical axis all the way down. That's how he's standing up. That axis correlates with the transverse plane, and that axis is that rotational axis. So I'm rotating about a vertical axis in this transverse plane of motion, okay? For your sagittal plane, all right, that's being cut straight up and down in half. The axis that correlates with that is your transverse axis, okay? So you have your, sagittal plane here, transverse axis, which goes across, okay? So if I'm bending forward around that axis, I'm in that sagittal plane, okay? The other plane is the frontal plane or the coronal plane, which kind of slices you from the side, almost like Han Solo in Star Wars, right? When he's like frozen like this, he's kind of frozen in that plane. And that plane, that axis that goes with the coronal plane is that AP axis. So that is your side bending axis. You're side bending in that plane around that axis, okay? All right, so that's planes of motion and axes. Landmarks, this is why we're really watching the video, right? It's landmarks. So for your posterior landmarks, let's come around the side here. So I'll loop this guy around, right? Your occipital protuberance, AKA the inion, is this whole area is your occipital protuberance. Try to say that 50 times fast. All right, so here's the giant scapula bone. People call it your, your shoulder blade, but now we're doctors. The acromion is this part, right? You have the spine of the scap going to the acromion. Your clavicle, your AC joint, your acromioclavicular joint is here, and you have the coracoid process, which is a hook off the front of that scapula. And that's where your pec attaches, pec minor, goes like this. Your short head bicep and your coracobrachialis attached there. That's always a board's question. And then you have your spinous process at T1. So we have C1, 2, 3, 4, 5, 6, 7. All right. And then you have T1 here with the first rib articulating with it. So that's an easy way to find T1 too. It's just like first rib, T1 right there. Okay. This is the spine of the scap, and if you follow it down, it is at the same level as that transverse process of T1, 2, 3, okay? So it goes right there. So that's an easy way to find T3 on somebody, is if you just follow this spine of the scapula right to T3. Then we have the medial border of the scapula. That's just this part right here. The inferior angle of the scapula is this little nubbin right here, and that correlates with T7. So we have 1, 2, 3, 4, 5, 6, 7. And this transverse process goes right to T7, that inferior angle of the scapula. For the costotransverse articulations, just like it sounds, transverse process articulating with the costal, the ribs, okay? So that is the joint for that. Iliac crest at the level of L4, okay? So it goes across. Now in females, these crests are wider and more kind of out laterally, and you might actually get more of it matching with, going towards L5 maybe. In some males, it's really high and in, and maybe it goes more towards L3. But generally, we say it correlates with L4 in most people, also known as the PSIS. That is this guy right here, PSIS, and that is going to correlate with S2. Okay, so all of the sacral S1, 2, 3, 4 they are fused, so it's kind of at that S2 level, but again, it's fused with S1, S3. So ischial tuberosity, that's our sits bones right here. You're sitting on these two. So if you sit and you got pain there, that's where hamstring muscles attach. That is your sits bones. You're sitting on those two bones. The ischial tuberosity is there. The intergluteal cleft, you would say that is the physician term for your butt crack. And that's not what we say as doctors. It's your intergluteal cleft now. So don't call people that. If you need to, just say, you're an intergluteal cleft. So can you stand next to our skeleton buddy here? This doesn't have tendons, but our human here does. So may I show that to the camera? So this is our Achilles tendon, right? The Achilles tendon is right here. He's got a solid one. Playing a lot of basketball? No? Maybe? Used to? I can tell. No, I can't. But still, that is your Achilles, and it goes right to the calcaneus, also known as your heel. So let's have you turn towards that way. This is your medial malleolus. Sorry. This bone right here is your medial malleolus. Your lateral malleolus is on the other side, laterally, right there. Okay? Now the spinous processes, these in general on our skeleton buddy here, we gotta name this guy. You have them in your lumbar spine, thoracic spine, cervical spine. Now if you really look in the cervical spine, see those? They're little nubbins. These are bifid. So some of these, not C1, but starting at C2, you have bifid spinous processes. That's a unique part about the cervical spine. All these guys are not bifid. They're just singular. Another unique feature of the cervical spine are these articular pillars, right? The joints that our neck has to move with. These do not exist in the thoracic spine or the lumbar spine. So these are the articular pillars we're palpating to determine where your neck alignment is in space, okay? You still have transverse processes and they're here. They're just smaller than thoracic spine, They're right here. If you really look, see this little blood vessel? This is your vertebral artery, and it actually goes through these little foramen that are in the cervical vertebrae. That is a very unique feature that can, cause some danger if you're manipulating the neck without any knowledge. You can put some strain on this blood vessel here, okay? So just be careful with that. As we mentioned, go up and down, both cervical, thoracic, lumbar spine. Here's a big old transverse process here, way down to the lumbar and up to the cervical spine. So those are our posterior landmarks, okay? Let's go to it would make sense to do maybe lateral or anterior, right? Probably. Anterior landmarks. So, ta-da! All right, so we've got our clavicle. We already discussed the clavicle a little bit here, right? You have your sternoclavicular joint. This is the manubrium of the sternum here, sternum in general, right? So manubrium means shield, gladiolus means sword, and xiphoid means xiphoid. What that means, but it means what? It means what? Spear. Yes, thank you, Dr. Healy. He's having lunch. Don't mind him, he's just eating. Sternoclavicular joint, clavicle, acromioclavicular joint, acromion, okay? This bone, and this is like a Jeopardy question, is the only attachment, bony attachment from the upper extremity to the axial skeleton. People love asking that. Jugular notch is this little notch right here. That is seen as at the level of T2, so that kind of correlates. If you go straight back, T2 is at that level. The second costal cartilage, again, first costal cartilage, second costal cartilage is here. Again, the costal cartilage is that cartilage that the ribs attach to, which attaches to the sternum. So all this little clear stuff, that's all cartilage. The ribs really are bony predominantly on this lateral and posterior side, but it's kind of soft around that anterior attachment. That's where you can get costochondritis, or you get inflammation of that region. Some people think that they're having a heart attack. A lot of times it's just musculoskeletal, especially if you can push and reproduce that pain. The sternoclavicular joint, which we talked about, SC joint, the AC joint, then we have the coracoid, which we touched on right here, over here, it's right there. There's a lot of ligaments that attach there. And then we have the greater tubercle of the humerus. So that is going to be this big, chunky tubercle, right? I've been saying nubbin, but that's not correct. It's tubercle. And then we have the lesser tubercle of the humerus, which is this guy right here. So lesser tubercle, greater, lesser, bigger, smaller, more lateral, kind of more medial and anterior, lateral, posterior. Okay, so get used to using those terms. Anterior superior iliac spine. Don't forget its cousin or brother or whatever you want to call it, the AIIS, the anterior inferior iliac spine. It's one of my favorite spines because I'm a major nerd and because the rectus femoris attaches there. The rectus femoris is one of the most commonly injured quadricep muscles because it is the only one that crosses the hip joint and the knee joint. Then we have pubic symphysis, this little gap right here. There's a little cartilage here. Very important for pregnant women to have some flexibility here so the baby's head can fit through. But then if they get stuck wide as DOs, we can fix it. We can make it reapproximate with OMT. So that's the pubic symphysis. Greater trochanter of the femur right here. That is a big trochanter, often implicated in like trochanteric bursitis. There's a little fluid bursa that can get inflamed, cause a lot of pain. That is where it is on the skeleton here. Then we have transverse process of L5. You can kind of see it. It's right here. That's the transverse process of L5, just above the sacrum. All right. This is often indicated where the iliolumbar ligament attaches to that transverse process to the iliac crest. This ligament here can cause a lot of pain. I don't think they have it on this guy, but I swear people do have it. That's anterior landmarks. Let's go to, we're done with posterior. Let's go to lateral. Ooh, lateral. Okay, this guy needs shoulder surgery. 1 second. All right, it's fixed. So, external auditory meatus, this little ear hole where you hear stuff, or put Q-tips in there when you're not technically supposed to, but I totally do. That is the external auditory meatus, okay? The angle of the mandible, if you're a true Chad, you got a big old angle of your mandible right here, right? So that is the angle. And then you have the greater tubercle of the humerus, and that's gonna be, we already talked about that, greater tubercle of the humerus. We're going down our list here. Lateral epicondyle of the humerus, right? So that lateral epicondyle implicated in tennis elbow, where you're doing a lot of extension, backhands. That is the lateral, and then your medial epicondyle is medial. It's this little guy right here. This is the medial epicondyle, implicated in golfer's elbow, where you're flexing or you're like golfing a lot. You get pain right there medially. Radial head. So when you're rotating, see how that radial head, that spins, right? That spins, and there's a ligament here that holds it in place. So that is your radial head. And you can see just as you move your arm, that's what spins. Olecranon process. That's a fancy way of saying you're the bony part of your elbow. Some people are like, that's my funny bone. But really that's you hitting your ulnar nerve, and we'll get into that sometime later. But that's the olecranon process right here. It's just that pointy part of your elbow, okay? Technically, that is part of your ulna, all right? And then we have the antecubital fossa. So that is essentially when people are like, yeah, look at that, I'm on TikTok. That is your antecubital fossa right there, okay? When you bend it, really painful to have tattooed. I'm not gonna get that tattoo. Then you have your anterior body line. That is just generally the anterior line as you look at the body from the side. You have your posterior body line, okay? Again, if someone has like a sway back, or if they're really kyphotic like this, they're gonna have a different line to their body. We have the cervical lordosis, this curvature. You also have a lordosis in your cervical spine, unless it's straightened on an x-ray, which is super common. Then you have a kyphosis of your thoracic spine, and even a little bit on your sacrum. So kyphosis, lordosis here. All right, and then you have your popliteal fossa. It's the other fossa, but it's behind your knee, popliteal space. Some people get a Baker cyst here over time, and it gets fluid filled, and you drain it, and it comes back. Lateral malalis, we already mentioned a little bit, but again, lateral malalis and your medial malalis. And the ankle in general is actually called the mortise joint, and some people go through med school and don't actually remember that, but if anyone says mortise joint, it's a weird word, that is essentially the whole ankle joint itself as it articulates with your feet here. Fibular head. So fibular head, this is your fibular head, okay? And you can see it right here. That's my fibular head. And as you evert and invert, it changes position, which we'll get into later. But in just identifying it, it's right there, okay? Mid-gravitational line. Okay, so the starred items on this list, which you guys have, or if you're my students you have, is your mid-gravitational line. That is called a plumb line, right? And they use that in construction and all that stuff. But what needs to go through that to have, let's say, perfect posture like this, maybe I'm exaggerating, but it's the external auditory meatus, the greater tubercle of the humerus, the lateral epicondyle of the humerus, and the lateral malalis all the way down here. So I wonder if our guy has perfect posture. He's got a little bit of a forward head carriage here. Look at that, okay? Now you guys tell me, do I have perfect posture? Don't tell me, you don't have to. We talked a little bit about directional positional terminology. So we have anterior or ventral, posterior or dorsal. Then you have superior or inferior, okay? Then we have medial or lateral. Then you have proximal, going kind of towards the center of the body, or distal, away from the body. And then you have superficial, which is like your skin, it's superficial. And then deep, which is like where your organs are, they're pretty deep. So something on the surface versus deep. Do you want to lie supine for me, sir? Since you already knew what that meant. And all right, so supine, right? Patient is supine. How do we know? He's lying on his spine. He's supine. You want to lie prone for me. So you flip over. This is our prone positioning. So we teach you guys doing a lot of soft tissue in this position on the thoracic. Everyone needs it. This guy's got some knots right there. You okay? You're alive? Because this is bad. Yeah, you need OMM. Let's see if you can get this one. Left lateral recumbent. Yeah, like a fish. He's flopping around like a fish. So if you are lying, scoot down a little more. Here's a trick for my students. Use this as your pillow. Yes. All right, other side. Right lateral recumbent. That is your right lateral recumbent, okay? Lying like a floppy fish on your right side. Can you lie like that? So it's kind of like you're hugging the table. So just stay in that position, but try to hug the table. Sorry, Sims. It's right semi-prone now. Can you abduct your shoulder? Good job. Can you adduct? Add it to the body. So the way I remember AB and adduction, AB is bringing things away. Add is you're adding it. So you just add it to the body. Flex your finger. Nice. Can you extend? Nice. Can you flex your bicep? Ugh. Can you extend your arm at the elbow and the shoulder, right? So like shoulder extension is this. Elbow extension is that, okay? Shoulder flexion is this. Elbow flexion is that. Wrist flexion is that, okay? Can you show me internal rotation of your shoulder? Good. Can you reach your back pocket? That's even more internal rotation. All right, now be like, I don't have money. Do that. That's literally an exercise, no money. That's shoulder external rotation. Can you adduct your fingers? Can you abduct your fingers? Abduction, adduction, they're added together. All right, and then we have that stuff. We did the feet. I think that's pretty good. See you in lab.